people make their way to the stage, I think I'll just stay down here and throw some questions out, a couple, until you guys become unshy, and then come to the mics and we'll bring you into the discussion. So I want to start with, there's been a lot of criticism this morning, things we can do better, and I joined in on the piling on. So I want to start with something a little more positive. I want to ask each of the panelists really quickly, what do we do, what does Alberta do really well now? You know, to start off, then we can get into a little bit of what we do less well. So do you want to start off, Carl? What do you do well?
Yeah.
Not personally, but as a system.
We provide excellent health care in a system that can be improved.
Mike?
I'd probably, at least from my knowledge of the other provinces, the relationships here, while they've gone through some rocky periods, are generally pretty good. And people are all very committed, want to work. And so I think there's a good foundation to build on.
So Dr. Strauss, looking from the outside, what's Alberta do well?
So I'm from the outside, but I'm actually from the inside as well. So I'm appointed at the University of Calgary as well. And I wanted to highlight that there is a tremendously talented pool of researchers here in Alberta. So a lot of clinical epidemiologists, health services researchers who are leading the world in advancing what we know about optimizing quality of care. And many of them are in the room today, people like Brenda Hemmelgarn and Finlay McAllister and Braden Manns, Bill Galley. And I think that they can be called upon as this discussion proceeds to really try and advance what you guys want to do to optimize stewardship. So I think to me that's a tremendous resource here in Alberta.
And Dr. Naylor, what jumps out at you? What does Alberta do well?
I would say it's the talent pool, Andre. It's Alberta has an extraordinary tradition of excellence in terms of health personnel, and that's not just the researchers, but the professionals in all areas. The other thing it's done well is because it's been affected by slump and boom more than other provinces. There's a resilience here in terms of policy making and adaptation. And so I think you've got a resilient set of experts and extraordinary base of talent.
Now I'm going to, because we have limited time, I'll switch topics for this side of the table, because that was an easy question that you were preparing for. And everybody said Dr. Galley's good, so we won't give him an opportunity. But I want to come back to the data, because you've all seen the data that was presented in the opening. What one thing jumped out at you as this is what has to change? You know, was it to have the highest health costs? Was it physician remuneration jumping? What was the one thing, David, that you said, wow, that has to change?
I think probably it's the fact that the whole system is extraordinarily expensive and we're not getting the outcomes. And for me, I guess when I look at it, it's how do we create that social contract between the physicians, the system, and the patients to deliver more quality or better quality.
And Peter, looking from the outside, when you saw that data, what surprised you?
Well, the wow factor for me was I realized I'm probably the lowest paid physician in this room. And I mean that seriously. That
I thought all you U.S. guys were fat cats.
No, I'm a government employee. But no, I think that and it is hard for me to sort of wrap my head around, so there's different costs of living issues, you have different tax structures, I don't know what the Canadian dollar is worth today, but it's not one to
very
one.
much.
Yeah, so I think it's challenging, but relatively speaking as a province, I mean, you're that much higher than the others, which did strike me as somewhat odd.
And before we go to I see there's questions already, so I want to get there, but Bill, I want to ask you one tough question. Talked about value, the word value kept coming up all morning. How do you measure value?
Yeah, there's more economists in the room than I'm just a dumb general internist. So, but I mean, the challenge is defining value, and value is a very multidimensional construct that depends on the perspective of the individuals. That there are values that relate to the payer perspective, value for the patient. And there is always the cost-value ratio that needs to be considered, and that's part of the discourse here. And we have people like Braden Manns, Mike from the discipline of economics, Eldon Spackman, who's a new recruit to the University of Calgary. We're excited about that. Defining value is shared challenge.
But what I took from your opening remarks is you're not getting enough value for money in Alberta. Is that fair?
It would seem, yes. And I think it's pretty clear. I asked the question of Carl tongue-in-cheek, is there any more money? And he shook his head a second time. I don't think that the problem is one of money, needing more money. I think it's getting more out of what we already put on the table.
And Carl, out of fairness, I'll ask you that. Are Albertans getting value for money for their physician payments?
Yes.
Okay. Then we'll go to the floor. Great. So go ahead. Tell us who you are and fire a question.
Sure. Michael Giuffre, I'm a pediatric cardiologist from Calgary. I'd like to direct my question to Professor Naylor. So, as a person in the grassroots delivery of care in Calgary, I'm confined in my decision-making by the system that I've inherited, the system that I must work within. And thereby it has its group of shackles that obviously influence my decisions on a daily basis. And when I look at the system that I work in, I see that if we take $18 billion as the amount we pay per year in Alberta, of which 15% or 14 or 15 billion is actually paid in towards the system to keep it working. And I see what small percentages is for physician remuneration. I would say that perhaps the question we're asking today towards physician remuneration is misplaced. Maybe the effort that we need to have in this room with all the minds is more towards changing that system. And what I'm concerned about is, what do you think is the actual trigger? What is the trigger point that says we need to switch from a hospital-based system of care to a community-based system of care, that instead of pouring money into institutes, that we actually disseminate the care into centers of excellence embedded in the community, that instead of these silos of care that we have institutionally based, that we actually shift towards integration in the community and shift care to where it belongs, close to our homes and out of the institutes. So my question to you really is, what does it take to shift $14 billion of an annual budget in AHS towards shifting that money out of their budget and actually back into the community where it belongs? What's that trigger point?
I was hoping you would not ask a question, because you said so many things I agree with. I could have just said yes and stopped. Yes, I agree that you can't over-focus on the physician envelope. That was one of the lessons of Ontario. If you get completely stuck on cutting physician incomes and capping, you miss the bigger picture where a lot of the action is. Yes, as others have said, Andre among them, we need to have a smarter system in terms of the handoffs and the reliance on community and home care versus institutional care. Yes, we need to have AHS integrally involved in this process of reform, because they have the delivery mechanisms under their aegis. But if I had, a magic bullet for moving the system in that direction, including the population health piece, by the way, which I spent a lot of time just 5 days ago in a talk covering, so we're all attuned to that one too. If I had to go there, it would be to bundle payments and budgets and governance, and have a lot of this led from a regional perspective with strong physician participation in governance and leadership. And the challenge is not so much the amount of money, and it's not even taking money away from doctors, because generally speaking that doesn't go down too well. The challenge is how the heck you get all the machinery to move in lockstep to make that happen, because there's about 6 moving pieces to make that go. And most of the time when integration in Canada has stalled, it's because it isn't simple. So what's happening elsewhere, and you see it in the US, is, okay, we'll do bundled payment around COPD, we'll do it around hip replacement, we'll do it in terms of a new way of blended capitation payment, so primary care docs are rewarded for keeping people out of hospital and dealing with ambulatory care sensitive conditions. It's all piecemeal, but at least it gets us moving in the direction you very strongly outlined, and that may be what Alberta has to do in the first place.
And Mike, do you want to touch on that briefly? Bundling, is that a way to go to bring about some change? Is that, we haven't talked a lot about it this morning, but.
Yeah, and I think it's all around bundling the payment around the scope of authority and the impact. So we have a lot of externalities in our system where sometimes the best thing to do from your own perspective, and people have their own operations and so on, is to almost put care somewhere else and so on. So bundling is an attempt to kind of match up that impact with the payment and make people accountable within that. So yeah, there has been some discussion on that. Alternative payment has been slow in Alberta for a lot of reasons. It's something we do need to do more work on.
Yeah, go ahead.
Hi, good morning. I'm Geeta Sharma. I'm the Endowed Chair in Aboriginal Health at the University of Alberta. So I want to follow on from what you had said, what do we not do well in Alberta, and from what Louis said about the 5% costing 67% of the healthcare budget. I would like to know your thoughts on how, and probably most importantly, when will we improve the situation in terms of the healthcare systems for the Aboriginal populations in Alberta?
So, Dr. Galley, do you want to tackle that? Aboriginal health is obviously important.
Yeah, this picks up on Dr. Franciscetti's comment about the social determinants of health. So I think that this is where those who think about healthcare as thinking that that's health, that's not the conversation, because there are so many challenges that relate to really health, not illness. And health, we all know, is not merely absence of disease. Health is a state of well-being that relates to many dimensions. Alberta actually has a very interesting strategy around the social policy framework that was developed by not the current government, a preceding governments, I think actually even 2 governments ago. And the Campus Alberta Public Health Collaborative had an interesting discussion of heavy focus on how the social determinants relate to health and disease. Obviously, the health of Aboriginal peoples or Indigenous peoples in Canada is a central piece in that, and it's really one of the big societal challenges that we have in Canada, your work and that of many in Calgary. Back to this point about talent pool, we have Cheryl Barnaby, Billy Thurston, many other people engaging Indigenous communities in the province to look at the health of Indigenous peoples. So a little bit of a rambling answer, but that's to say the upstream determinants of health that have actually nothing to do with health care systems other than perhaps some of the preventive services that are available through primary care. Those have to be a focus, but that's not a Ministry of Health focus exclusively. That's a multi-ministry mandate that I feel governments don't necessarily attend to very well because of the need for collaboration across multiple ministries to think about housing. Why does Alberta derive revenue from gambling? Just as an example. Fundamentally harmful to the families of this province and to the health of individuals. That's a health issue, but it's not in the Ministry of Health. So just to underline the multi-ministry nature of the challenge.
Go ahead.
Glenn Sumner, cardiology from Calgary. Question again directed to Dr. Naylor. I just wonder if you could identify what you see as the major barriers to implementing the recommendations in your report, which clearly involves a number of creative minds.
I think, thank you, I'll be very brief. The barrier is the constant federal, provincial, territorial jockeying. We have a country that seems to be bound and determined to make itself smaller, not bigger. And the same obsession with silos and segmentation is what confounds integration in each of the provinces separately. It's going to take a very different model of leadership, back to Lauren Terrell's comment, a model of partnership rather than direction and oversight and pseudo-accountability if we're ever going to move this health system forward.
Go ahead.
Thank you. I'm Don Phillip. I'm from the School of Public Health, University of Alberta. And I think all the speakers so far really give us a really good insight as to what the challenge is here, how do we get beyond that. We've heard a lot about our low performance. We've heard a lot about the need for more integration. And the last comment, the last session was about stewardship, and I'm concerned that maybe our concept of stewardship is a bit too narrow. I mean, if you look at these other countries that do better than us, most of them have quite a different culture of relationships among the professions. The ability to substitute skills, to move into teams, is not hampered in the same way by all the regulatory agencies we have in Canada, by rigid payment systems, by a whole number of other cultural things that have taken place. And I think stewardship has to be defined here as not something that government can make happen or even AHS can make happen. It has to come from the professions themselves working together in a different model. How are we going to get there? Because this is focused on physicians as stewards of resources. I don't argue for a moment that physicians have a major, major role in that area. But a lot of things when we talk about chronic disease, basically to manage that takes a lot of other professional skills that can be brought in. If you look at other countries, a lot of these countries that have better performance than us, you don't even get to see a physician on your first encounter. You'll see a whole bunch of other people. We're stuck in a model here. If somebody says we got one foot in the cement, how are we going to get out of that? I look forward to comments from the panel in that regard. Thank you.
Now, Dr. Price, you studied primary care a lot. Is there enough interdisciplinary care? Does everybody practice to their full scope of practice and so on? What are your experiences?
So I guess that's been the big challenge in Ontario. We've created what we've called family health teams, which are large interdisciplinary, interprofessional teams. And we are now starting to see the benefits from that interprofessional team-based care. The challenge was that when we first created those teams, and realistically it's only about 25% of the population that has access to those family health teams, so that is a fundamental equity problem. But when we first created those teams, there was the expectation that within a year or two we would start to see outstanding results. And of course, as we all know, if you're going to create a team and start to create team-based cultures and patterns of practice, it takes time. And it's been almost a decade. We are now starting to see those outcomes. As we're starting to gather the data, we are actually seeing improvements in access, improvements in outcomes, rehospitalizations, and we're starting to see a little bit of a differentiation between the traditional models and the newer models of team-based care. So the message I would give is it does seem to make a difference. It does allow for an impact in the social determinants of health, preventative care, and all those things, but you need to have patience. In other words, the CE at the end of the patients. It takes time, and it has to be purposefully thought to see the outcomes, and it's just like stay the course.
And Dr. Noor, in Alberta, do the professions work together well enough? Do doctors work enough with nurses, PSWs, nurse practitioners, all that, or are they still quite working in isolation?
Well, there's an evolving experience similar to what was described in Ontario with the primary care networks here, which are team-based care units. And I think some of the same considerations are relevant. It takes some time to demonstrate improvement, but there's a great sense of commitment and participation in that across the province.
Go ahead.
Okay, Robert Davies, a physician in Calgary. My comments and questions are directed mostly for Peter, actually. I'm very interested in what you have to say today. First one is just going back to the first presentation, and it struck you in terms of payment or payment movement to physicians in Alberta, and I just want to speak briefly in defense of the profession without sounding too defensive, in that the time frame in which you look at those pay changes is extremely important. And that in Canada we had a period of time in the 1990s where physicians were seen as a cost center to be controlled, and in this province we had a 5% pay reduction. And what happened is through the 2000s we had a period of catch-up, whereas in order to make sure that we were recruiting and retaining physicians, the pendulum swung the other way. So if you look at that graph of payments to Alberta physicians looking back to 1990 or 1995, the variance in terms of growth with other provinces is quite small. The other point is that there is an absolute dollar difference between us and other provinces right now, but what that needs to respect is that a lot of those physician payments, that's not net to physicians. There's overhead to be paid in Alberta because of the success of the economy over the last 15 years. our overhead payments, which vary between different specialties, between 35, 50% or higher. Our cost to employ people and to rent space and do all of those other things is actually much higher than in other provinces. So looking at graphs of physician gross payments is actually quite misleading, in that if you were looking at net of overhead, you might actually see a decline over time, even as those physician payments are going up in terms of net. And that, I feel that fee-for-service has been, demonized a little bit. What it does do is it does give you a kind of a one-to-one, payoff in terms of productivity. And I'm interested, my first question for you, I guess, is in your system, how do you balance alternative payment mechanisms that make sure that you're getting proper productivity and output from physicians, and at the same time are making sure that you're not getting too much output and that your resource utilization is reasonable? And my second question, I guess, is that we have had a lot of discussion about, or are alluding to a lot of discussion about, different payment mechanisms. What I haven't heard a lot about in terms of a broader approach to stewardship is a type of communication and collaboration that you really need to make that happen. So you want to look at a group of physicians and say you need to be stewards of your resources. I would say one thing that we do not do well in Alberta yet is that we don't actually get good information about what things cost, and a reciprocal exchange of information that would allow us to be proper stewards of resources. So my second question, I guess, is in your system, what sort of information or metrics or reporting do individual physicians or groups of physicians get about how they're utilizing resources?
Okay, I think I got that.
So give us a little. Give us a little bit of this without giving us your whole talk from this afternoon.
Yeah. Well,
sorry. Okay.
Yeah. No, but I will say one thing about. So first of all, when it hit me as sort of the wow factor, that was sort of the first thing that came to mind. But I think on the salaries, I think many in the United States were actually paid less than what we should be paid. We also have big disparities between primary care and specialty care in the U.S. But within the VA system, and I'm going to talk a little bit about this afternoon, I mean, we're actually very similar in terms of size and number of people that we take care of, but we're all salaried. And so the way we manage it is to try to do it through RVUs, and with a single integrated medical record, we keep track of every possible way that workload can be captured. So telephone visits are captured, nurse visits are captured, anything with pharmacies captured. So we try to put that all together to say, if you're going to manage a panel of patients, how many should that be, and what is the workload associated with it? So it's not perfect by any means, but being salaried, I think it has some benefits. I think in terms of getting back to metrics and information going back, VA's pendulum has swung back and forth a few times on that. We're, I think, right now at 512 different quality metrics. I mean, as a chief of medicine, I cannot keep track of them. It drives me crazy. They recently announced they wanted to reduce it to 26. If they can even get it to 200, I'd be happy. So I think we have a lot of data that we feed back, but I'm going to... I might see if I have time to talk later about how the primary care providers especially just feel both overwhelmed with data, and they get a lot of data but not a lot of information. So it's a double-edged sword when you have a lot of data.
So let's get in one last question. We're already over time, but if you have a quick question.
It was going to be two, Andre. Blair O'Neill, I'm the Associate Chief Medical Officer for Strategic Clinical Networks here in Alberta. I still practice as a cardiologist here in town as well. I guess this is mostly to AMA, and due respect to the previous speaker. At the IHI forum in Orlando, Don Berwick, who's the guru of quality, said fee-for-service is the Berlin Wall of medical care. And I think it is a perverse incentive. As somebody who's trying to change physician behavior, it becomes very difficult to reduce utilization where it's going to have a direct impact on your wallet, and that's no shame. It's just the way we're built as human beings. So how do we, I mean, I know AMA's had very advanced discussions about bundled payments, different payment structures. How do we actually get off, given that we're starting from so far behind elsewhere in the country? If there was time left, I was going to ask Dr. Naylor about his innovation. That was the number one recommendation as far as trying to get this system to experiment and change. How do you see that actually helping us to become the system that we need to become as a high-performing system here in Alberta?
Mike, do you want to start? How do you get that movement going away from fee-for-service?
I think the next priority will be around the, at least making a blended option available for primary care physicians. That's been in the works for some time in terms of development. There are a lot of reasons that have inhibited that introduction, which have ranged from even technical issues and so on. And I know, Blair, you're aware of some of that. So I do think there is room for that in Alberta. There's a lot more to go in that area. That would be the first one, I would think. The other suggestion has been made has been around the bundled payments, and some of the strategic clinical networks have been promoting that as well. And I think that would be those would be the major one. But I think the main one is to get going on the primary care option, that actually the primary care leadership, the physicians, I mean, have actually been pushing for that for a while, as you know.
Great. So thanks to all our panelists. Dr. Galley is going to set us up for the afternoon very briefly and tell you where lunch is. And we look forward to seeing you again this afternoon.
All right.